So I'm really excited to be here today, and thank you all for coming. I know some of you have come actually quite a distance. So before we get into the slides and everything, let me just kind of give you an overview of why we're going to be talking about chronic conditions, dementia, and caregiving today. And this arose out of my work with a number of doctors and healthcare professionals that were really noticing that their patients that had cognitive impairment, that is a whole spectrum, from mild to profound dementia, that they also had typically multiple chronic or long-term conditions. And that we expect older adults to be able to manage many chronic conditions that often have multiple medications, and these medications or injections have to be given at different times. They have to change their diet and lifestyle, and this is complicated when you're cognitively intact, let alone when you have cognitive impairment. And so much of the burden would fall on caregivers of these older adults. And they found that caregivers rarely had any training on how to do this, very little understanding of the chronic conditions, and often they themselves had multiple chronic conditions they were trying to take care of. And so that's really what motivated a whole line of research, and I'm going to touch on a little bit of that today. So I'm just going to acknowledge I'm really grateful for foundations in New Zealand that are supporting my visit. They include Aging Well National Science Challenge and Canterbury Healthcare of the Elderly Education Service, Education Trust. And much of the work you're going to see has been funded by the National Institutes of Health, their National Institute of Aging, and I have no conflicts of interest. So this, as I told you, some of the motivation behind this work, it also stems from, in the US, our Department of Health and Human Services published something called the Multiple Chronic Conditions, a Strategic Framework. And I believe you often call these long-term conditions, chronic conditions. And it really asked us to be engaging more in shared decision-making because patients are facing multiple diseases, and they're often, in the US, their healthcare is fractured. So they may go to the cardiologist for their heart disease. They may go to a doctor for their kidney disease. They may see a different doctor for their diabetes. And they may be getting conflicting information, and there really isn't a sharing and setting of what matters most to that person. What is that goal setting? And so this strategic framework called for setting that and really partnering in decision making. And to really realize that not all patients are the same. And as we age, we find that there's more diversity in the mix of conditions people have and their ability to care for them. And treatments don't always work the same. So we know you can take a pill for your blood pressure, and it's not going to work the same on everybody because there's a different mix of diseases that person has, and so we realize there's more and more variation. So let's talk a little bit about the top common chronic conditions in older adults. And so this is from the National Council on Aging. And so here we can see high blood pressure, most common condition, high cholesterol. We see arthritis is very common, and this is 65 and older. Once you get into the 80s, you're seeing that these are very, very common, and we see that 80% of people over 65 have at least one chronic condition, and over 2/3 have at least two chronic conditions. And so we can see there's several heart diseases, kidney diseases, depression, and we see Alzheimer's disease and other dementias is about 11%, but we have to understand that many cognitive impairments are not diagnosed or are underdiagnosed. And that comes as a result of stigmas. It comes as a result of people feeling that nothing can be done. But what they don't realize is there may be services provided, such as services in New Zealand are provided, that it's often an access to other forms of care, and that there may be medication changes that may allow cognition to remain stable for longer before declining. So it is not a hopeless situation, and often our social factors are very important in the maintaining of cognitive health. I'm going to be talking a lot about functional disabilities, and these are really based on the concept of activities of daily living. And these are considered essential activities a person must be able to perform themselves to be able to live independently. So these are relatively basic things. These are eating, bathing, dressing, getting from a chair to a bed, toileting, walking, or some sort of moving around, if that's with an assisted device. And we know that these can change over time. So much of the work I have done has been on functional disability, and we know that there may be a period, especially after hospitalization, that a person may need assistance in one or more of these activities, but they may be able to recover that function. So it's not once a person has a disability, it's a permanent disability, but they're changing all the time. So this slide is from the Ministry of Health here in New Zealand, and they also take a multimorbidity or multiple condition approach. And I thought this was a lovely slide from the National Institute for Clinical Excellence guidelines in 2016, because you can see all the elements, and their focus is about improving the quality of life. So it's very patient-centered, and those, as I said, it's very important to assess that person's needs. What are their needs? What are their goals and treatment preferences? What are their priorities? And that's really where we need to keep our focus. If we see over here the benefits and risks of following single disease guidelines, at least in the US, we have developed a lot of guidelines that other countries follow as well, and it's really based on a single disease approach with a biologic outcome. So maybe your left ejection fraction is improved if you take this drug, but rarely does anybody feel that, and rarely is that anybody's goal or their preference. What they want to do is they want to walk up the stairs, because their bedroom's on the second floor and their kitchen's on the first floor, and they just want to be able to be in their house. And they're saying, I'm having chest pain, I feel fatigued, I feel dizzy when I try and go up the stairs. And so there's a real shift between how we've developed and tested medicines and medical procedures and devices from how people want to live their lives and what's important to them. And so that's why when we consider guidelines that are solely based on following a single disease protocols, they may not fit for older adults. So let's talk a little bit about cognition and function. So if I was only more clever, here we go. So if we see this blue box up here, in the UK in 2016, they found that about 3 in 5 carers say that their health has been affected negatively by caring for someone with dementia. So often our focus is on there's a person, they have a condition, that's where our focus is. But the carers also face burdens. Remember, some carers are older, they also have their own health conditions. Some carers are adult children, and they're the sandwich generation. They're taking care of their own kids, they're taking care of their parents. So we really have to realize that care is affected by the health as well. So having the cognitive impairments and then functional disabilities, those activities of daily living that are required. Much of that, at least in the US, is provided by carers that are unpaid, right? These are family members, spouses, partners, adult children, cousins, extended family. And we've found that providing substantial help is associated with the caregiver having difficulties with emotional regulation, their physical health, as well as their finances. So we've tried to expand where the research was very focused on that person with dementia and their behaviors. And what we really want to look at is the management of those chronic conditions for that person who can't manage them themselves. Is there a role in that, and what does that really matter? So here we can see these are US numbers. This is from the AARP, which is the Association for the Advancement of Retired People. And we see that families in the US spend nearly $7,000 out of pocket for caregiving, and nearly $12,000 US dollars on average if that caregiver doesn't live with the person, so they live at some distance. And family caregivers provide $470 billion US dollars in unpaid care. So when you want to say, is this an expensive condition? And should we fund social services? And should we improve the quality of life, not just medically, because I think generally medical services are doing an excellent job. But in the US, it's $470 billion, and that's using our minimum wage scale. And we know that more than 3 in 4 family caregivers are incurring out-of-pocket costs as a result of caregiving. So that's beyond that $470 billion. And family caregivers are spending on average nearly 20% of their income on caregiving activities. So that's why providing these social supports and services and well-being factors at least has a real monetary cost. It's a hidden cost, but it's real. I'd like to just draw your attention. New Zealand is paying attention to this, and you have publications such as Improving the Lives of People with Dementia. The estimate was from a few years ago that 50,000 people have dementia in New Zealand. We're going to expect that to grow to 78,000 by 2026. And it's very costly. It's costing, that's the medical care, is costing $1 billion annually in New Zealand. And these costs are expected to rise as the number of people with dementia are increasing because the population's aging. And your Ministry of Health publication, Health Losses in New Zealand from 2013, said that dementia was one of the top 4 leading causes of health loss in people 75 or older. So it's not just Americans that are facing this. I really liked this graphic from New Zealand Carers Strategy and Action Plan. There may be some newer information that the panelists will be sharing with us. This is from your Ministry of Social Development, and it really recognizes it. What I really like is that it's very person-centered. It recognizes the roles of family and friends, awareness, keeping well. So this is not conceptualizing aging as a disease. Aging is not a disease. Aging is a good process. There's a lot that older lives contain, and so what we need to do is keep supporting that. Yes, we face challenges, but aging is not a disease. You may have diseases, but there's social supports that can, as well as your health supports, that can address this. I'm going to talk to you about a concept of a type of caregiver called a care partner. And we define this a little differently than just a broad caregiver. And so we define it as a person who sat with their care recipient during a doctor visit in the last year, or who helped the care recipient with a prescribed medication in the last month. Some caregivers may be providing support in those activities of daily living. They may be cooking meals, they may be doing laundry, housekeeping, any number of things. We're really trying to focus on that management of those chronic conditions, so we're looking at this concept of a care partner. So this was defined, so we have a nationally represented study of Americans. We call it the National Health and Aging Trends Study. It is of Medicare is an American insurance scheme for older people. It's supported by the government. People who are 65 or older are eligible for that program. So we use data from that, and we looked at, as I showed you earlier, there were a number of very common chronic conditions. So we looked at several of those that were symptomatic, that you could feel you have them, and non-symptomatic, but such as high cholesterol, high blood pressure, and poor thyroid function. But those may affect your well-being in a number of ways. Whoops. So in this study, they have a number of cognitive measures, and they didn't have a physician per se interview each person to decide if they had dementia or not, but they used a number of common screening scales to ascertain if a person had normal cognition, possible dementia, or probable dementia. And so we're going to talk a little bit about just probable dementia in this data set, because it kind of points out underdiagnosis or not understanding your diagnoses. And so here we can see of the individuals with probable dementia, over 19% were diagnosed, but they were unaware of really what dementia was or that condition. And the characteristics associated with that was they had less education, they attended medical visits alone. So remember, one of the roles of the care partner was they went with the person to medical visits. And they had fewer functional impairments. So they're pretty intact in being able to transfer, move around, bathe, dress, things like that. But maybe more alarming is nearly 40% were undiagnosed, but by these clinical measures, we would say they have probable dementia. So there's a lot of undiagnosis, and the characteristics associated with that was being Hispanic, which is a very large ethnic minority in the US, and then the rest were the same. Less education, attended medical visits alone, and had fewer functional impairments. So then we had a question. So among these multimorbid persons with cognitive impairment, does having a care partner modify the impact of these chronic conditions on the number of activities of daily living that that person could perform? And again, we're kind of motivated by in the US, there's 40 million older adults, and of those, 8 million, or 20%, have multiple chronic conditions. And then we can see that those with chronic conditions and ADL disabilities are about double in the spending. And so collectively, we're looking at more than $140 billion when you're looking at the cost of people that have multiple chronic conditions and functional impairments. So here's a little bit about the data. This is going to generalize to about 3.6 million Americans. And we can see the vast majority. So these are all people with cognitive impairment by this screener and 2 or more of these chronic conditions. And we can see those that have a care partner present, which would be the vast majority. They tend to be older. They tend to need more help in more activities. And a higher proportion, quite a few, nearly half, had been in the hospital within 12 months of baseline. If we just want to kind of look at, are there some differences in the presentation of diseases? So we can go back to that earlier graphic of what were common diseases, and we see there's a lot of similarities. So we see the atrial fibrillation, a heart disease, is more common. The benign prostatic hyperplasia that affects men is more is actually more common in those that don't have a care partner, while kidney disease, one of those most common diseases, much higher than the population average. We have lung disease, chronic obstructive pulmonary disease, depression's very common. Nearly a third of the people have depression, as well as heart failure being much higher than the population average. Nearly half of the people have heart failure, and then another heart disease called ischemic heart disease. And then we've also seen far more people have had strokes that have care partners. So this is very small, and so don't worry about the numbers. I'm just going to tell you what this slide means. So we were trying to see if having a care partner helps you maintain some function. So what we found was, and this just came out last year, chronic kidney disease worsens your function, as does depression and heart failure. However, having a care partner, all of these are negative signs, so that means that they all actually reduce the negative effect of the diseases. So let me try and show you this in another way, because figures are nicer than numbers. So here we can look at not having a care partner if you have chronic kidney disease. And this is a risk ratio, so it greatly increases the amount of risk you have of having more functional disabilities. If you do have a care partner, you're less likely to have as much. Depression, we see a similar where those that are absent, much higher risk than those who have a care partner. So that care partner is doing a number of different things. And heart failure, again, absent, we see it's higher than when the care partner is present. So care partners are not, and these were very simply defined, right? This was attending a medical consultation, generally with a GP or a specialist, and helping take prescribed medications. That's it. That's the only thing we were defining it on. So then we were also looked at, were there socio-demographic factors or characteristics of caregivers that were determinants of rest home admission, and we're modeling this at the same time as those functional limitations. Because some earlier work said when the person can't do these functions, that's why they end up in the rest home. But we're saying, well, is it also characteristics of that relationship between the care partner, the caregiver, and the care recipient? And one of the things that we found very interesting is if you looked at people who, in the US, who use long-term services to support their disabilities, those who are non-elderly are predominantly in the community, while those who are seniors, over on the left side, you see that they are about 50-50 being in rest homes and receiving community-based care. So there's a real question of, even though these are nearly the same amount of people, nearly 2 million in each group, in the US, we're better at providing services for younger people to stay in the community than we are for older people. So these are just some characteristics of the people we were studying. And again, this is from that generalizable group to the US. And so I'm just going to bring your attention, if I can make this point, to kind of the cohabitation status is your living status. So of those who were eventually admitted to the rest home, this column, we have about 48% that were living alone, and 26% with a partner. Living with others was only about 6%, and living with a partner or others was also very low. When we look at some characteristics of those who were admitted to a rest home over here, we can see about a third had dementia compared to about 21% who did not. We saw that they worsened in their function over time. They had worse self-rated health, but it's about a similar number of chronic conditions. But when we look at those who had a caregiver at any point, we can see that of those who went to a rest home, 20% had a paid caregiver, because at some point, some individuals have such needs that families are paying out of pocket in the US. I think you may have a better healthcare system here, but we often have to pay out of pocket for caregiving. Those who had a medically supportive caregiver, or what we've been calling a care partner, about 62% did. Fewer had a partner caregiver. Child caregivers, both groups had over 90% of people, whether they went to a rest home or not, had a child caregiver. So again, that sandwich generation, taking care of kids, taking care of parents. Friends and neighbors. You know, it's really maybe surprising in the US context, but 26 and over 30% of just friends and neighbors as a caregiver. I think in groups in New Zealand, you have much more community support and extended family than possibly in the US. If we look at any type of family caregiver, almost 100%, over 98%. And often we have multiple caregiver sources. So what did we find out? So in this group, 11%, a little over 11% went to a rest home. I should tell you something about American rest homes and how we pay for them. Very interesting. You won't want to do this. So how do you get into one? Well, you better go to a hospital and be admitted for 3 days, not 2 days, not 1 day, and not for observation. You have to be admitted for 3 or more days. Then you can be discharged. And for 20 days, our insurance plan will pay 100%. At day 21, it starts declining until day 100, where it's $0 until a whole calendar year has happened, or you spend another 3 days admitted to the hospital. So, what do you think happens? The most common length of nursing home stay in the US is 20 days. Going to the hospital is really costly, and we're going to see a few numbers on that in a few minutes. But think about this gatekeeping system that requires you to go back to the hospital to get that refreshed. That might not be a very economically efficient system. So when we looked at some of these values, we found that those who go to the rest home had 3 times greater worsening in their functional status, that nearly everyone, nearly 93%, had a caregiver at some point. And we saw factors that were associated with rest home was having a low level of education, while it was protective in the US setting if you lived with a partner or you lived with other people. Also, the number of caregivers, oddly, you'd think more caregivers the better. But we're finding is you start to get sort of fractured care, because as the number of caregivers went up, it actually increased your risk of going to a rest home, as well as worsening functional status. When we started to look at the characteristics of the care providers, then we saw if you had a medically supportive caregiver, you actually were increasing your risk of going to a care home. So this really seems to be a marker that the person's struggling to take care of their own medical needs. So someone else is having to help with that, while again, that partner caregiver is protective, no effect of the child caregiver, no effect of neighbor. These are protective, but they're not statistically significant, but there could be some information there. So let's get back to our focus of that older adult and the research to improve the lives of elders. So there were some high priority evidence gaps that were recognized in a publication in the US that helped set research priorities. And these were really about service utilization, such as hospitals, emergency services, disease-specific outcomes, such as diabetes, chronic pain, cardiovascular disease, depression, falls, stroke, all those things that we saw were having very large effects earlier. Among those who have multiple chronic conditions and in the presence of moderate to severe cognitive impairment. So that's where there were research efforts, and so we're going to try and address those. So you have a beautiful hospital here at Burwood. I'm really lucky to be based there with Dr. Jamieson and his group for a month. I've only been here a few days, and it's been an excellent experience. And so as we think about hospitalizations, I wanted to examine the associations between these chronic conditions and costs, because in the US, we're capitalists, we care about costs, among people with cognitive impairment in 2 or more of these chronic conditions. Because, that poor management of those chronic conditions, they're going to exacerbate, and they're either going to have to seek care in the emergency services or be hospitalized. That hospitalization is a marker for kind of poor health management, and also in the US setting at least, kind of poor care coordination, because our handoffs, sometimes people fall through the cracks during those care transitions. So again, we have our NHATS folks. We're looking over 5 years of longitudinal data. The 21% discontinued when someone goes into a rest home. In this data set, we no longer follow them. So about 21% were discontinued because they're in a rest home, and nearly half of the people died. These people are old and sick. We can see that nearly 29% have 6 or more conditions, and they all have cognitive impairment. So these are risks of going to the hospital for each condition, and then these are costs, and these are rates. So let me tell you a little bit about how to read this. So an acute myocardial infarction is having had a heart attack, right? Really increases your risk. This is having a previous heart attack, not the reason you went to the hospital. Having had one in the past really increases your risk of going to the hospital. In US dollars, just the cost of the hospitalization is going to be over 23,000 US dollars relative to those who did not previously have a heart attack. What is the rate? So what's a rate? It's like a speed in a car, right? 100 kilometers per hour. So this is, you're going to have 126 persons admitted who've had a previous heart attack for every 100 persons per year. So that means some of these people are going more than once, right? So this is a big indicator of people with dementia and multiple chronic conditions. What else do we find? Atrial fibrillation. I seem to keep repeating myself. It's a bad disease. Don't get it. Over $13,000, 91 per 100 person years. They're almost all going to the hospital every year. We see that with chronic kidney disease. Only about $13,000, 98 per 100 persons. What else do we have? Heart failure. No good. Don't get it. Depression. Ischemic heart disease. Rheumatoid and osteoarthritis. So from that very first top 10 chronic conditions, we can see this poor man in his camera. He's to chase me around. You can see those top 10. These are not rare conditions, and these are costly. They're frequent hospitalizations. And so if we're trying to target things, and can we move that to ambulatory care, we can start to focus on things. Now that was direct costs, and you might say, we have this great health scheme here, so, you know, the government pays. I don't know how your government makes money, but ours in the US taxes the people, so I'm paying. But look at this. Those blue lines are direct medical costs. That's not just a hospital, that's your GP visit, that's all the costs, your medical devices, X, Y, and Z. These are our diseases. Everything just got more expensive because I have a lot more healthcare costs. But look at the societal costs. What is societal? Societal is counting the hours that were reported by informal caregivers for just those 6 activities. Not going to the doctor's visits, not cooking, not cleaning, not doing everything else they do. Just those 6 activities, how much time they spent. And suddenly you take something like atrial fibrillation, that direct medical costs were only around $35,000 US, and now it's about $55,000 US. So that hidden cost of informal, unpaid caregiving that most of you either are doing or you will do or you have done, that is a real cost. And that is the importance of providing these social services and well-being supports and all the ways that you try and connect your people with dementia or multiple chronic conditions or all elders to services and why that's so important. So we also looked at, you'd say, well, hospitalization, that's pretty intense, you know. What about just emergency services? So we looked at that too, and we call it, oddly enough, treat and release. It sounds like you're catching fish and letting them go, but you know, you're catching old sick people and letting them go. And so we wanted to look at, well, were those conditions different, right, for those people for emergency visits? So again, you're getting really good at this. We're generalizing to about 3.6 million older Americans. They all have at least the 2 conditions, and they all have possible or probable dementia. And remember, these are sick people. Nearly 30% had 6 or more conditions. Over 35% were over 85 years old. These are our very vulnerable, complex patients. About 94% had more than one informal caregiver, and nearly 70% are helping with those medical visits. So here the picture is a little different. And I want you to think, remember what really happens. You have an acute event. You're sent to the emergency department. From there, they adjudicate you have to be admitted or can you go home? So we're looking at the people that can be treated and be able to go back to their home in this, which is different than we saw for the hospitalization. So here, and so these we can think, could this care have occurred in the clinic, the GP practice or clinical setting, as opposed to having to use emergency services, which are very disruptive to the person's life. And so here we can see chronic kidney disease, we keep hearing about that, depression, heart failure, the ischemic heart disease, and the rheumatoid and osteoarthritis. So a lot of very painful conditions. Often that pain is driving the person to seek help. And so we can also see that these rates, again, still remain pretty high. So whether they're being admitted to the hospital or they're seeking emergency services in the US, they can be very high. And this just came out this month in the American Journal of Emergency Medicine. So I'm just going to kind of summarize what we've been talking about so the panel has time to have an open discussion with you. One of the things we need to kind of focus on in this is the caregivers aren't really getting support in the US to understand the activities they need to do to provide care to their care recipient, that person with dementia, with multiple conditions. We know that the symptom presentation may be different for a person with cognition, how they're expressing the symptoms, how somebody might recognize them. And that really hasn't been embedded in any sort of caregiver support programs. They're starting to develop videos and some other resources in the US, but the caregiver has really been kind of left behind in providing the care, and they're really doing the bulk of the everyday care of that person. And so when we look at what are really the activities they're doing, we see that nearly 8% are giving shots or injections. You're thinking about things around diabetes and some other medications. Managing medical tasks. Helping with skin wounds. Over 20% are helping with skin care. Older people's skin can get very frail and can tear. So there's a lot of needs for skin care. Our insurance practices are complicated. Thank goodness, I hope yours are easier. But many of these conditions require a special diet. So over 27% are having to have special diets. And here, nearly 50% are having to keep track of medications. It can be really complex, the medication regimes. If you look at what pill you're supposed to take at what time, before a meal, after a meal, that you have to have a complex pill minder when you're taking 15 or more medications at different times of the day. It can be the older adults complain that just managing their medical conditions is a full-time job. It's taking them away from their social activities. They're feeling more isolated. And suddenly we're giving drug after a drug to treat the side effects of the previous drug. So it's very complex. That around 55% are helping speak to that medical provider, and over 60% are helping with medical appointments. So these care givers are doing a lot of medical activities of which we find they need more support. And so with that, I don't want to leave you in a negative space. These things are related. We have found that care partners can actually improve function for some conditions. We believe some conditions can be managed better in an ambulatory setting in your GP practices and not necessarily have to go through emergent care or in some cases hospitalizations if they can be stabilized. That although dementia may not have a direct treatment, there's many supports and services both to the person living with dementia and their caregiver, and that this all affects the person's ability to live at home as long as possible. And again, I'm going to leave you with this slide. This is from your own Ministry of Health. It has 9 key areas to improve the quality of life for people with dementia. I know that New Zealand is very committed to this, and I think you have a lot of promises to keep growing these services. And thank you very much for your attention.